ahead and start the recordings. How's that?
Okay. My class starts at 6 o'clock. Good evening, everybody. Welcome to the March Los Angeles City Health Commission meeting. Will the city clerk call the roll, please?
Yes, thank you. Commissioner Apra being recorded. Commissioner Avila, I do not see that present. Commissioner Estradas is absent tonight. Commissioner Gavidia.
Here, present.
Thank you. Commissioner Grimmick. Yes, he's also absent tonight. Commissioner Hisrich. Thank you. Commissioner Cato. Cato, thank you. Commissioner Carfani. Not here. Commissioner Loinas. She is absent tonight, and I believe I just saw Commissioner Carfani being admitted. Commissioner Carfani? I'll come back. Commissioner Mandel.
Present, and Commissioner Carfani, you're muted, so you can say present if you don't mind.
Present.
Thank you.
Thank you. Commissioner Assey? Present. Thank you. Commissioner Shannon? Present. And Commissioner Soroka?
Present.
And 8 commissioners present, a quorum.
Thank you. Moving on, I've asked for approval of the minutes from the commission meeting. Second. So that's approved by Kano and seconded by Soroka. Any questions or concerns about the minutes? Any amendments to the minutes? Seeing none, anybody who was not at that meeting cannot vote or abstain from the vote. Erica, would you call a vote?
Yes, I will. Commissioner Gavidia.
Approved.
Commissioner Hisrich.
Approved.
Commissioner Cato.
Approved.
Commissioner Carfani.
Approved.
Commissioner Lemos absent. Commissioner Mandel.
Approved.
Commissioner Assey was absent at that meeting. So Commissioner Shannon.
Approved.
Commissioner Soroka.
Approved.
And that item is approved.
Thank you. Moving on to neighborhood council comment. I don't see anybody from the neighborhood council. Will the interns let me know if anybody's in that queue? I don't see any of them. Seeing none, we'll move on to public comment. Could you open up the queue to the public comment, please?
Yes, thank you, President Mandel. We are admitting our first speaker. Good evening, Francesca Laura with the Los Angeles City Health Commission. Please press star 6 to unmute yourself and state your name and the agenda item you are speaking on.
Can you give her more instructions, please?
Yes. Please press star 6 to unmute yourself and state your name and the agenda item you are speaking on. Again, that's star 6 to unmute yourself. If we do not hear from the speaker in the next 30 seconds, we will move on to our next speaker.
Go to the next.
All right, we'll be admitting our next speaker. Good evening. We're on the line with the Los Angeles City Health Commission. Caller with extension 425. Please press star 6 to unmute yourself and state your name and the agenda item you are speaking on. Hi, can you hear me? Yes. Okay. Awesome. Hi, I'm Lana from the AIDS Healthcare Foundation. I'm speaking generally and on item number 3. Yes, item number 3. So first of all, generally, can you hear me? Yes, we can hear you. Okay, first of all, the audio system here needs an update, and what's going through the web is distorted and inaudible, and I both cannot be on the phone to provide comment and be on the phone to listen into the meeting. Even this process here is really quite confusing. And also the audio recordings after the fact are fuzzy and hard to listen to. So I ask that you please modernize this for accountability's sake. And secondly, I'm very eager to hear the presentation for API Health tonight on sexually transmitted infections. It's so vital that we continue to problem solve the high rate of STIs in the U.S. Prior to COVID-19, STI rates were epidemic proportions and climbing still. And while we talk about better health, we need to include lowering the rates of STIs. We're supposed to be socially distancing, but the AHF STI clinics are as busy as they've ever been, and the client behaviors have not changed at all. So while your ear is currently turned towards sexual health, I hope you will continue to support and fund services that prevent, test, and treat STIs and HIV. It's vital. These things are not taking a backseat as new infections come to the forefront. We still have to take care of these others as well. Thank you.
Thank you for coming today, and thank you for your input. We appreciate it. We'll look into the audio. It is the desire of the Commission and the City Council that everybody can hear these meetings as well as be able to participate. Moving on, is there somebody else in the queue?
Yes. So thank you, Speaker. I'm letting in the next speaker. Good evening, speakers. We're on the line with the Los Angeles City Health Commission. Caller under the name Caller_user_1. Please press star 6 to unmute yourself and state your name and the agenda item you're speaking on. Again, that's star 6 to unmute yourself and state your name and the agenda item you're speaking on.
Muted.
You can keep on talking. Commission President, the speaker's off topic.
Thank you, Speaker. That was the end of 2 minutes. We will now be welcoming our next speaker. Good evening, Speaker. You are on the line with the Los Angeles City Health Commission. Call with extension number 323. Please press star 6 to unmute yourself and state your name and the agenda item you're speaking on. Extension number 323, please press star 6 and unmute yourself. Last call number, extension number 323, please press star 6 to unmute yourself and state your name.
You hear me? You hear me, lady?
Yes, we can hear you.
Okay. COVID-19 is dangerous. Look at all the niggers in LA sleeping on sidewalking streets because Jackass Eric Garcetti and his budget morons do not provide adequate housing for lots of people who sleep on fucking sidewalking streets, you bitch. Why that? Why criminals behave in such a untolerable asshole attitude towards American people who need cold-blood assistance? You know, Joe Sleepyhead Biden? Full of shit. He will speak English like I do, which that's why
Mr. President, the speaker is off topic.
No, shut the fuck up, asshole. No, asshole. Shut the fuck up. I'm speaking. I got the floor, you jackass. Who the fuck are you, asshole, interrupting me? You fucking American stupid fool? I'm American too. I tell you what to go to hell. J.O.B., asshole. Don't fuck with my time, nigga. So like I said, America is fucked up. We got COVID surgery, got COVID crisis, and we also have an immigration crisis because you niggas want to tear down my border. What? I'm talking with you. What? I'm talking chopped. Oh, thank you, Mom. Tell that stupid son of a bitch not to interrupt me, you fucking asshole. God bless America. God bless.
Alright, that was 2 minutes. I'm now going to be admitting in the next speaker. Good evening, Speaker. You are on the line with the Los Angeles City Health Commission. Caller with the name Caller User 2, please press star 6 to unmute yourself and state your name and the agenda item you are speaking on. That's star 6 to unmute yourself.
Hello?
Yes, we can hear you.
Herman for the record. Why do we still have Eric Garcetti as a mayor? Hasn't he proven his story like Mr. Remo Cuomo from New York, killing 15,000 elderly people, and now part of a big scandal of sexual abuse like Jose Luis Weaver and Frankie Godoy? Or Mitchell England, who's now doing prison time in Mopac at the end of June.
Commission
So I want to remind the world,
spoken earlier.
incompetent, stupid motherfucking kids.
Is there belief that the speaker has spoken before?
You can let him speak.
Okay. Call user 2, you may press *6 to unmute yourself and resume speaking.
Am I still on, you jackass? Can you hear me? Dude, you fucking retard, stop fucking with my time. My time's important. The same way it's important to see all you fucking homeless people sleeping on the floor like a street show, even during COVID, even during your closes, even during your surge, and even during your time when you're fucking lying, your stupid Gavin Rico Newsom haven't done shit appropriately to take an action to relieve all this fucking crime. So on behalf of Joe Biden, fuck you, 42 1983, follow the BAIN Act, and next time under the BAIN Act 54950 to 54963, Joe Biden his office, fuck you too.
If his time's up, let the next speaker in, please.
Thank you, speak for the question, by speaker. We're now welcoming our last speaker. Deputy Speaker, we're on the line with the Los Angeles City Health Commission. Caller under the name IPA Guest. Caller under the name IPA Guest, please press *6 to unmute yourself and state your name and what you're you're speaking on. Again, that's *6 to unmute yourself. Can you hear me? Hello?
Yes, we can hear you.
If you can hear me, I need to mute myself. Please don't kick me out of the meeting. I need the speaker, I need to be the speaker mute.
Yeah, we hear you. You're loud and clear. Go ahead, please. I think you're muted. We hear you.
You hear me? Hello?
Yeah.
Yes, we can hear you.
Okay, this is Francisco. Okay, Joyce, I need to be muted on my microphone so I can not have to go through the system.
I see.
Okay, so don't kick me out because I can't be joining in again.
Sure, thank you so much.
Just for clarification, I'm sorry, this is Rita Moreno, Office of the City Clerk. The recording should be on Google Meet, not on the Zoom meeting. The Zoom meeting will be closed as soon as public comment has been taken. So the recording should be occurring on the Google Meet, not the Zoom meeting.
Thank you. Do you have public comment? We've kind of lost them.
Yes, we have one more public comment. We will admit that in right now. Good evening, speaker. You are on the line with the Los Angeles City Health Commission. Call's extension number, call in user_3. Please press *6 to unmute yourself and state your name and the agenda item you're speaking on.
Are they there?
Call with extension number, call -in user_3. Please press *6 to unmute yourself and state your name and agenda. I believe the caller just left, so that concludes our public comment.
Thank you very much. Seeing no other public comment, let's move on to the agenda items. It's my great pleasure to introduce Dr. Karen Rogers, who's an associate professor of pediatrics at both Children's Hospital of Los Angeles and the USC, University of Southern California Keck School of Medicine, and one of the leading experts on Project HEAL. Dr. Rogers, we're honored that you would take time to present to us. The floor is yours. Thank you very much for attending.
Thank you so much for having me. I'm a Google Meets newbie, so sorry I'm a little slow with the technology. Okay, so I was asked to talk today about the impact of the remote schooling on our children in Los Angeles, and I'll try to keep it to about 10 to 15 minutes, and just to give like a little overview and a little bit of information about what we think we know. So first of all, I want to point out that we actually have limited objective information about the overall impact on children of the transition to online school. We know that there are children who have experienced and are experiencing learning loss, that there is increased exposure for children to adverse childhood events because of being out of school, that children have lost needed social emotional supports associated with being at school, that children are struggling with mental health impacts of the pandemic, and that many children may be experiencing reduced attachment to school, increased risk of poor attendance, and dropout from this pivot to remote schooling. But we really don't have any objective data, wide-scale data on the learning impact or even on the socio-emotional impact of children as a population experiencing this transition. We do have some ideas from an international case. So the 2014 Ebola epidemic led to school closings in 3 countries for 9 months. And those countries reported increased physical and sexual abuse of children, increased rates of teen pregnancy, and that when schools reopened, many children never returned to school. Schooling, the education system in those 3 countries is very different from ours and involves school fees, and there are also some cultural and economic differences in the countries as a whole. But I think that this is an example that we do well to be keeping in mind as we think about our children in Los Angeles. And then another identified impact in those West African countries is that girls were disproportionately affected by the closures. I think that really the story of school, the impact of school closures on children is a story of health disparity. So here's an example of one child who has reliable internet at home. He owns his own laptop. His parents are able to form a pandemic pod and hire a nanny to oversee online learning. This is a child with access to outdoor space for active daily play and who is able to continue to participate in extracurricular activities and whose family maintains safety and financial security. And when you think about that child's impact from the pandemic, it's going to be significantly different than a child who is using a school Chromebook and maybe a hotspot or unreliable internet access, whose mother is continuing to work as an essential worker in a low-paid position where she is coming into contact daily with the public, whose economic support from his father has been reduced because of the economic consequences of the pandemic, a child who lives in an overcrowded situation without access to outdoor space, and whose family's protective instincts make them reluctant to let the children leave home to go play outside. This is a child whose safety and financial security and that of his family are in significant jeopardy during the pandemic. And his experience with online learning and the overall change in access to resources that's resulted from the safer at home situation is going to be significantly different than that of a child with more resources. And so I think that really that's the essential story of how the pandemic has impacted children. Children in marginalized communities carry an additional stress burden of racism and discrimination, in addition to the burden of reduced access to needed educational and other community supports and increased economic hardship. Children with special education needs may not have received the same type of support that they would have in school. There are many children who are exposed to maltreatment at home who haven't had a safe place to go or someone to identify and address the abuse. Children who live in poverty and rely on school nutrition and enrichment programs, and bereaved children who've lost a loved one to COVID. These are all children who are going to be facing a disparate impact from this remote learning situation for children. We think of children as innately resilient, that we know that kids can bounce back, that when a child has the opportunity to receive good schooling, for example, their educational outcomes often improve significantly. But, you know, resilience isn't something that resides within a child individually. Resilience comes from community factors, it comes from family factors, and it comes from some of the individual child factors. Some of which are, you know, we're born with, having an adaptable temperament and cognitive resources, but many of which also come from the experiences that we have in our environments. So I think some of the concerns that we should be having about the impact of the online schooling for children include not just the learning loss, but the impact on their mental health, their socialization, their physical well-being, their opportunity to have enriching experiences, and they're going to have a lot of needs when they're returning to school and seeing things return more to a new version of normal. So kids are going to need additional education support to make up for learning losses, but also children who have been staying at home within their family environment for now, it's been a year, will have fallen out of practice for social skills and not have that year's worth of opportunity to learn. So they'll need support to pick up those lost skills and to continue to grow. And then I think it's important also to keep in mind that the pandemic itself, as well as some of the other significant events that we've experienced in our community in the past year, have been traumatic for many of us. And that includes traumatic for our children. And so some children will respond to a return to school with a lot of enthusiasm and excitement. They'll quickly adapt. Many other children will really struggle with the trauma that the past year has brought to them. And those children who've been in unsafe environments will be particularly impacted. And then finally, children will need access to mental health support, both primary mental health support and specialty mental health support for those with more severe needs. So I think, you know, when we think about the ways that the pandemic may have impacted children in our community, it's not just about what we actually know and what the data show, but what we can understand from an overview of how childhood development unfolds and the impact of adversity on a developing child's brain. We know that children who are exposed to multiple adverse events have their brain architecture can be show long-term impacts from that adversity, and that can have lifelong health effects as well. And so I think we can anticipate that our kids in Los Angeles are going to need additional support in order to demonstrate their natural inherent resilience in coping with this.
Wonderful. We'll open up to some questions from the commissioners. I'll start off, Chair, with a couple. One is, has Children's Hospital seen an uptick in the number of kids that are coming in year over year with mental health issues and or suicidal ideations since last March?
Yes, we have had a significant increase in referrals to our mental health program at CHLA. We also have existing clients who were already being seen for mental health services who have shown, increased need. We have not been able to move children out of treatment, graduate children from mental health treatment because of also the stress of the pandemic. So both of those things have happened.
Do you have a quantifiable number? Do you have a percentage increase, or in actual raw numbers, what the numbers are, approximately?
Our referrals overall for mental health services at CHLA have roughly doubled since last year. There are some other changes that have happened. The hospital changed our referral system that maybe contributed to some of that increase, but I think a significant amount of it is due to pandemic-related stress.
And LA City is short on psychiatric beds in general, and in regards to pediatrics, do you believe that prior to the pandemic, from your vantage point, are there enough pediatric and adolescent mental health beds in the city of Los Angeles? And then since the pandemic began, what's your sense of those numbers?
So, the most common reason for hospitalization for children in California is psychiatric, mental health-related medical needs. And we have a terrible shortage of psychiatric beds in the community. I don't know that I can speak to changes that have happened in that as a result of the pandemic, but I can say that I think we have a shortage of available beds for kids.
And then lastly, revenue stream both for clinical services and also inpatient care, is for the most part, is that mostly Medi-Cal, or do private insurances or HMOs also pay what you would consider to be reasonable rates in order to maintain a program?
I work in a Medi-Cal funded program, specialty mental health program, so that is definitely my vantage point. But Children's Hospital, I can tell you, has been working diligently to also provide mental health services to commercially insured children, and it has been a real challenge over the years. We do have a behavioral health initiative ongoing to address those needs for children with commercial insurance. That's been a more recent effort on our part. Previously, honestly, the reimbursement rate from commercial insurance was so much lower that it was hard fiscally to make the argument that we could provide those services.
Is the Medicaid or Medi-Cal reimbursement rate enough to balance your budget, or do you have to supplement it with donations, or does Children's Hospital subsidize you with grant funding? We are a Department of Mental Health contract mental health agency, so we have a contract with the Department of Mental Health to provide specialty mental health services for children at CHLA. And that contract actually, I think, funds services at a level that we are able to sustain. Wonderful. Any other commissioners have questions? I don't see.
Sorry.
Go ahead, Brian.
Hi, Ms. Rogers. Brian Gavidia, thank you for your presentation. Quick question. What recommendations in terms of investment would you suggest, to help fill the gaps for these disparities, particularly that have been created with remote learning?
If I had a magic wand, I would recommend everything. But I think that one of the things that has always kind of puzzled me is the fact that LA schools don't offer any kind of guidance counseling support at the elementary level or the lower school level. I think that there's an opportunity for some early intervention there that's really missed. And so if I ran the world, I would look at increasing mental health supports and counseling supports for kids in schools at all ages. That would be one thing. And then I think that opportunities for additional educational time for kids to make up for the losses that they've had. When I came to Los Angeles 15 years ago, summer school was available to children routinely. And then when the fiscal crisis happened in 2010, the summer school was significantly cut back. So now it's primarily children, I think, who are behind in their schooling. But those kinds of opportunities, I think, could be really valuable for kids who are going to be on their way back from a really difficult year. And then, of course, also more access to mental health services. You know, we have a waiting list for services, and I think, you know, we don't have enough mental health providers in the county. We have a tremendous shortage of child psychiatry resources in the county and the state as well. Those would be some of the things that I would really like to see increase.
Thank you.
Commissioner Cotto, you have a question. Ron, you're muted. Commissioner Cotto, there you go.
Thank you, Dr. Rogers, for your presentation. In your PowerPoint, you mentioned that there's limited objective data about transitioning to online. You know, there's data showing that, you know, early childhood education, you know, improves the achievement among kids if it's done early, and but the consequences are for those that are in the low-income areas, which you cited, you know, through your two examples. And so, as CHLA, what percentage, I know you said that you work more with Medicare, but what percentage do you think are coming from those low-income areas seeking help? Or do you think a vast majority of them can't seek help and are just sort of, you know, out there without assistance?
Yeah, it sounds like you're asking if the children, like the most disadvantaged children, are able to access mental health care. And I can tell you that I would tell you that at CHLA, about 80% of the kids that we work with are from Latino families, and another 10% from African American families. So we're definitely seeing kids from racial and ethnic groups that tend to be more disadvantaged in our community. We also get referrals from far away from Children's Hospital. And some of that's because people want to bring their child to CHLA thinking it's the best care, but for many families it's really difficult to find good care for their child in their own community, particularly when their child has a co-occurring medical or developmental disability. So we get folks who are reaching out to us for services from as far as 60 miles away.
Because culturally, most of the races that might be affected socioeconomically, they may not really seek mental services. And, you mentioned Hispanic and blacks, but, there's a lot of Asian Americans as well. And if that percentage doesn't even show up, it just shows you that, culturally they're so inhibited thinking that, it's a taboo to ask for help. And, is there a way to try to, get some data on that group?
I think you're right. Asian American people have been identified as less likely to seek mental health care, needed mental health care. Actually, my office is in Koreatown, and yet we have very few folks from the Korean community who are requesting services from Children's Hospital. So I think that information it's out there, not pandemic related, but in terms of mental health care in general. And I think that the only way to make that kind of a change is going to be working with those communities to increase awareness and address the stigma that can be associated with seeking mental health care.
I think the pandemic is compounding the problem even more, because if they're not seeking and it's getting worse and they're not seeking, it's just...
Well, one of the unfortunate impacts on children of being, out of school is that they're not coming into contact with other caring adults who are identifying the challenges that they're having and helping them to connect with support. So whether that's because a child is being maltreated at home or because there are mental health needs, like those opportunities to connect with supports that they would be normally getting at school aren't present.
Thank you, Dr. Rogers.
Any other commissioners with a question? Not seeing any other. I'll have one more, Dr. Rogers. You talked about the data from West Africa after the Ebola crisis. Was there follow-up data to see either suicide or suicide attempts? Did they increase in the year or 18 months after the pandemic that was in West Africa?
Yeah, that's a really good question. We certainly have some anecdotal reports of increases in suicide among particularly adolescents during this time. I think adolescents feel the isolation so acutely, many of them, and some of the stresses of adolescent social media, I think, are magnified by the pandemic. I'm not aware of any data about those West African countries and changes in suicide rates. I wish I could tell you the answer, but I don't know.
In your following research and or analysis, things of that nature come about, we would really love if you could send it our way and you can email them to us so the Commission could be updated upon the mental health issues, both either in the African situation or as you go along in Los Angeles, if you're seeing increased numbers of suicide attempts, increased numbers of patients coming into your clinic, waiting lists at your clinic that were not there beforehand, or other issues. We'd always like to know about that so we can properly advise the City Council and the Mayor. Any other commissioners? Seeing none, Dr. Rogers, we're honored that you would come to us tonight. We're honored that you would address us. We're thrilled with the great work that you do at Children's Hospital and at KEC, educating young physicians about the needs of mental health for adolescents and children. It's desperately needed, and we truly appreciate all that. You're welcome to continue and watch the rest of the meeting. We will not take it personal, and I'm sure that the elite professors from Stanford will not be upset if you left to care of other business, but you're welcome to stay on. We truly appreciate it. If you did stay on, if you do have questions after the commissioners ask questions, you're more than welcome to jump in. We're honored and appreciate your coming to speak to us today. Thank you very much.
Thank you. Thank you so much. I'm so glad to have the opportunity to talk with you today.
Moving on to agenda item number 2. We're very privileged to have 2 leading economists from Stanford University and the Hoover Institute, Professors Eric Hanasek and Mac Raymond are going to present. We're thrilled to have you here. One of the nice things about the pandemic, I think there's several actually, but one of the nice things about the pandemic is that the Commission has had the ability to bring in world-renowned experts in their field, whether that be from New Zealand, from the United Kingdom, or from Northern California. So we're thrilled to have you with us today to talk about the economic impacts of closing schools, not short-term, but long-term as well. Professors, the floor is yours. Thank you very much.
Okay, just a sec. Trying to get my screen. Here we go. Are you able to see my screen? Okay, great. Well, I'd like to thank you for the opportunity to be with you and to express my appreciation for putting Dr. Rogers first. Her presentation was both fascinating and also incredibly pertinent to the things that I want to talk about today. And in fact, she took such great care of the topic that mine is going to be very brief. I've actually edited some of my slides while she was talking because she covered a lot of what I was going to talk about. Again, my name is Mackie Raymond, and I'm the director of the Center for Research on Education Outcomes at Stanford University. And my team has partnered with over 30 states over the last 15 years to do really detailed studies about what happens to students as they go through K-12 public education in the United States. And 20 of those states joined with us last summer to try to get a handle on how much learning loss the students in their schools actually experienced from the time the schools were closed in the middle of March 2020 till the end of that school year. Now, clearly, this is only a slice of the problem that we're confronting now, and part of what I'll do today is to speak a little bit more about where we are as a year has come and gone. But why do you care about the loss of a particular year of test data? Last year, every single state was given permission to cancel their test programs. It was clearly the right thing to do. Kids were being displaced. The education system was moving from class-based to some form of remote instruction. There were all kinds of challenges that families and students and educators were facing. So testing went away in 2020. Okay, but what does that mean for us? Well, not only does it mean that we didn't know what kids learned last year, but it actually has a dramatic effect on our ability to find out what happens to children over a longer period of time. When we have two test scores back-to-back, that allows us to see how much progress a student has made from one year to the next. And growth, academic progress, is actually a better way of thinking about how much learning happens for a student as a result of the schools that they attend. When we only have a snapshot of what a student knows at any one particular moment in time, something we call achievement or status, that measure actually combines what schooling they get with other influences such as their innate endowment, how much they learned before, what kinds of family supports they have, and so on. So status or achievement scores are pretty fuzzy. And so we like to actually use sequential estimates of what students know, because a lot of those same factors cancel out, and you end up with a measure of solid progress that's directly related to what happens in schools. And so in the last 2020 assessments, last spring, we lost the ability to find out how much they'd grown from 2019, and we now in 2021 don't have a base for understanding what they learned, how much they grew in this current year. And there's some question that we'll talk about in a moment about what assessments are going to look like this year as well. Well, so my team took the challenge and said, well, all right, we don't know exactly what every single student would have learned had they been in school the entire year, but we can create statistical models to actually estimate what those learnings would have been and then estimate how much of that was lost as a result of the closing of school buildings and the pivot to remote learning and the impact of the COVID pandemic. And those are the things that I want to present to you today. If you look across all of the students that we included in all 20 states that we looked at, on average, students lost 64%. That's 2/3 of a year of learning in reading. And in math, they lost more than a full year. You might say, how is that possible? Because the schools only closed in the middle of March, and the middle of March till the end of the school year is only about 60 days. But it turns out that not only did they lose all of that forward learning from March to June, and I think it's fair to say that in most cases, learning pretty much ground to a halt. There were some exceptions, and we'll talk about that in a minute. But they also lost what's called consolidation, which is a process on the sort of neuroscience of learning that says it takes multiple reintroductions of material in order for students to actually consolidate those concepts and really build those into base knowledge. And so the reach back of what learning loss impacts we see are about the fact that they lost the forward-looking classroom time from March to June, but they also lost the period of time of having all of those earlier concepts reintroduced and re-related to each other. And so in reading, it's as though learning stopped in January. And in math, which is a more difficult construct for students to learn in general, went all the way back to the beginning of the school year. So that's the story at the average. But what we found, and this is correlated with Dr. Rogers' presentation, is that we had huge variation in those findings. The students that had lower achievement going into the school year were among the ones that had the larger losses. And so we found great variation across schools and across student groups. So low-income students and schools that had high percentages of minority and poverty students were the ones that had the largest learning losses. And this is really dramatic because they were the ones that were coming in already behind the 8 ball. We know about achievement gaps to begin with. Those gaps have magnified as a result of the onset of the pandemic. So what does this mean for us? What this means is we have a model of schooling that assumes that students show up in September generally in the same place with their knowledge and able to pick up and move forward together generally at the same pace with a single teacher, 25, 30 students in a classroom. We have this idea that we have common starting points and we have a fixed pace of learning. And that is not going to happen, and it has not happened this year. We have a much wider range of starting points for students, and we have a much different impact in terms of their pace of learning. This is a study that we have underway now with my team. And all of the things that Dr. Rogers spoke of the socio-emotional and traumatic impacts of COVID, are in fact differently changing the ways that students learn. And I have to say, it's hard for me to imagine schools being equipped to handle the kinds of students' needs that are coming into schools this year. So what do we look at? We found the variation was as much as 50% greater in reading and almost 100% greater in math. By that I mean the worst case scenarios that we saw for students in the pandemic analysis that we did was that they were losing in reading 100% of their year as opposed to 2/3. That's 50% greater. And in math, they were losing substantially more than a full year of learning that made it even worse for the worst case kids. So what do we look for now? Well, here we are a year later, and we're in the season where, according to the federal law that governs elementary and secondary education, we are supposed to be moving into a period of spring assessments again. And you may have heard that the Biden administration stated the expectation that states would, in fact, test their kids and then gave some flexibility to that exercise. As Dr. Rogers mentioned earlier, we don't have any hard data. We have very little hard data on what kids actually know at this point. And we will be 2 years without that information if states walk away from testing their students. We know the pandemic is continuing. Professor Hanishek is going to give you some additional estimates of what that looks like now. But that says to me that the gaps that we saw and the differences across students that we saw at the end of last year have only gotten bigger this year. And so I think what you're going to see starting next year is this is the year that we'll actually figure out how bad it is. And the the necessary period of recovery is not going to be as quick as we might hope or we might expect. We think in our estimates that it's probably going to take 6 to 10 years to get kids back on track, and it's going to take us several years to even figure out what that's going to look like. Recovery is going to have a very different face on it tomorrow than it does for any kind of schooling that we recognize today. So with that, I'm going to turn it over for questions, and I'd be happy to answer any that you have. Or to Hanashek go next, and we can talk on that.
Dr. Slides did not slide through as you were talking.
No kidding.
No. You're giving a great talk in lecture. I just wasn't sure if you wanted to point things out on the slides. And it's possible it was just me, but I think it did not advance.
Nobody got advanced? Really?
No.
Okay.
So you might want to flip through those again quickly. We got the gist of what you were saying, but I know you worked hard in putting this together, the slide set, so you might want to get it to work.
Okay, let's see if we can get it to work. Hold on just a second. It's not letting me share.
Okay. You did send out your slides to us prior to the meeting, so we all have the slides, and the general public actually has the slides too, because they're available through the commission website. What I suggest is two things. One is let us go to Professor Hanashek, and then Dr. Raymond, if you drop off and jump back in for some reason, and I am a total technophobe, I cannot tell you why, sometimes then you'll be able to share it. And after Dr. Hanashek does his talk, we'll give you a shot to go back through them again if we can. Does that make sense to you?
I'd be happy to try. Thank you.
Wonderful, thank you. We truly appreciate your talk. I don't want to interrupt you when you were talking. You were on such a great roll, and we were getting the gist of it without the slides. But I know you work hard on the slides, so it'd be nice to see them. Professor Hanashek, you're up.
Okay, thanks. Well, thank you very much for having me join you. There's been a lot of talk recently about the economic costs in general of the pandemic. These costs have generally centered on questions of unemployment, of businesses that have closed down, and other things. What I'm going to talk to you about today is the economic costs of the learning losses that both Dr. Rogers and Dr. Raymond talked about before. It turns out that the economic cost of the learning losses just dwarf all of the other costs that we've been talking about, the unemployment cost and the businesses going out and so forth. So let me give you a little idea of where we're at in terms of the current estimates of economic costs. We're obviously not through with all of this yet, but I'll give you my best guess of where we are in March of 2021. There's no doubt that there were significant learning losses from universal closures. Mackie Raymond just showed us her estimates. I think that they're actually conservative because her estimates were done largely in the fall, early fall, and did not take into account the fact that schools in many California cities and in many cities across the nations haven't really opened up to their old ways of doing business, and we have
quite substantial anecdotal evidence, not hard evidence, that in fact the hybrid learning and the remote learning has not been at the same pace as the learning that we had in 2019 before the pandemic. We will, maybe not for a long time, know the full extent of the harm, but we do have some very clear estimates based upon the data we have that is starting to come in. And as both Dr. Rogers and Dr. Raymond suggested, there have been very disproportionate impacts of all of the learning losses. Kids from more advantaged families have, in one way or another, generally done better, certainly on average, and in many cases even better than they were before, through various aids that their parents give them and other learning pods, etc. But what we're seeing is this growing economic cost of remote learning. And it has been so hard to get people to pay any attention to this that I now refer to it, paraphrasing an author, this is the issue that must not be named. And what I want to do is walk you through what are some estimates of these costs. Now, what we know and what drives this whole set of estimates is that skills of people matter. People that know more and have higher skills, cognitive skills, earn more on average throughout their lifetime. And what we'll get into soon is that nations that have a more skilled population grow faster and have stronger economies. Both of these add up to tremendous economic losses. Now, last summer, a colleague of mine, Rutger Wolfman at the IFO Institute in Munich, and I prepared some estimates of the economic impacts of learning losses from the school closures starting last March. These estimates were prepared for the G20 meetings where the ministers from the largest 20 economies of the world were discussing where we were at. We did these estimates in August of 2020, and the estimates we did there were very simple. They assumed that over the summer we would get back to normal, and that the September 2020 schools would look just about the way they did in 2019, and that we were just looking at the estimates of what the closures did for the U.S. economy and for U.S. citizens. That obviously didn't happen, so I'll update these estimates. But let me just start with those. In August of 2020, if you take estimates such as what Mackie presented on the lost learning and translate those roughly into school year equivalents, because that's easier to talk about than standard deviations of test scores and other things. In school year equivalents, probably the best estimate was that on average, students lost a third of a year of schooling from March through the summer. And then if you estimate what's the impact of that on their future earnings, because we know that learning correlates to lifetime earnings, our best estimates in August were that the average student in the cohort that was locked out of schools with the school closures and the pandemic lost 3% of their lifetime earnings.
Professor, your slides aren't moving on either if you're trying to.
They're moving on mine. What is this? What kind of thing do you have? I'm sorry.
It's Google, so I don't know. I can't make a political comment about that.
Okay. Well,
you have to click each slide. You have to bring it out of presentation mode and click each slide.
Okay, I have to click each slide, I'm told.
Yeah, that works. You just did it.
Okay. Here we are in August 2020, the best estimate was 1/3 of the year, which led to 3% lost earnings. In February of 2021, my best estimate is somewhere between 6 and 9% of the lifetime earnings of the average student who has been through this COVID experience and has lost schooling. 6 to 9% of lifetime earnings. Now, that's obviously, by the way, also larger for students that didn't have the average gains, as was discussed by both previous speakers, that there's a disproportionate impact which will be larger than 6 to 9%. This is not the only story. Part of the story is that the U.S. in the future will be worse off because it will have a less skilled population, and economic growth is highly related to the skill of the population. This lower skill of the population, well, let me see if I can figure out how to do this. You're seeing, okay. In August of 2020, we estimated that average national income, gross domestic product, GDP, would be 1.5% lower for the remainder of the century. That, again, is an underestimate now, given what we know, that the schooling did not in September return to the 2019 levels. And what would the current estimates be? The current estimates would be that U.S. GDP is 3 to 4% less throughout the remainder of the century. Now, here's where we get into numbers that nobody understands. We measure gross domestic product GDP in trillions of dollars. Who knows what $1 trillion is? In total, we're at a GDP today of between 20 and $21 trillion. The estimate of the present value in terms of current dollars of this lost earnings in February 21 is $28 trillion. So when people are talking about the cost of the surge in unemployment that we had after the initial lockdowns, when they talk about the businesses that have gone under because of the lockdowns, those estimates are much, much smaller than this, because we're talking about essentially over the remainder of the century, will lose the equivalent of over a year of the total production in the U.S., not the difference between going from 4 to 7% or 4 to 9% unemployment. We're talking about a total year's loss. Now, these estimates you can think of as permanent unless we can make the schools better than they were. If we just return to the 2019 schools, these are permanent losses. The kids that suffered these will on average face these lower earnings. The nation will suffer more. So what you have to do is think about how could we make schools better than they were in 2019. Well, this is a tough problem, but there are some hints. One of the hints was what Dr. Raymond was talking about, of paying more attention to the individual students and teaching them where they're at. In other words, individualizing instruction as opposed to trying to teach to some average that is no longer there. Now, this is one of the things that we've known we should do before the pandemic, but the pandemic makes it essential that we start thinking in those ways. The second thing that gets a bit controversial in some discussions is that we knew in 2019 and before that there are very large differences in the effectiveness of individual teachers. Some teachers are better than others in terms of the learning of their kids. And that's looking at what they did in class. What we have is anecdotal evidence, again, no really hard evidence, but that some teachers are much better at remote learning than others. I'm sure some of you have kids, and you've been looking over their shoulders, and you see that some people are really good at this remote learning, and some people aren't. They're probably not, as best we can tell, exactly the same people who do well with in-class instruction. But we knew beforehand that we should be paying attention to the effectiveness of teachers, but now it really becomes important. And we should use the teachers that are good at remote instruction more intensively at remote instruction. And we should use the teachers that are good at in-class instruction more intensively at in-class instruction than we did before. With that, we might have a chance of making up for these learning losses and avoiding the economic costs that I've talked about. Thank you. That's where I'll leave you with sort of a dire message that could be turned into something positive, but it's going to take a lot of work.
So the $28 trillion would be over the next 75 years, basically, is what you're saying?
Yes, but it's all converted into current dollars. So it's in present value terms if you're into finance things. Many of this comes from growth later on in 30 years from now, but I've translated the value of something 30 years from now to today. And that's the size of a bank account that you would need to pay back over the rest of the century, that whole stream of losses.
So one thing that we know, or we're seeing, is that some people talk about a K-shaped recovery, in that we know that there are different populations within our diverse country economically. If you looked at that impact, what that $28 trillion would have, if it's not fixed, do you have an idea of what percentage or which quartiles of the population from an economic point of view are going to be most adversely affected, or is it going to be widespread on the entire economy and on all the population?
So, Dr. Mandel, part of it is widespread, but when we talked about the individual impacts on earnings, you can see dramatically differences in the impacts on disadvantaged kids in the bottom quartile of the learning distribution, which is correlated with socioeconomic background, when our schools have not been able to make up for that. And one of the things that's in the back of this whole story is that we have a lot of research that suggests that individual earnings are directly related to how much people know, to their individual skills. In the United States, this relationship is stronger than in almost all other developed countries. That the U.S. rewards skills more than almost all other countries. But if you just play that backwards, it says we punish the lack of skills more than almost all other countries. And so the people that have been hurt the most with these skills are the ones that are going to be punished the most.
Wonderful. Thank you for a great presentation. What I'll ask you to do is to close your slides, and let's try to see if Dr. Raymond could quickly go through her slides, and then I'll open up to the commissioners for their questions. To both of you.
Dr. Raymond, do you have
I'm on it.
Okay. I have confidence that she can do it.
She's done it many times already, but not with Google Meet.
Okay, so here, can you see my slide deck?
Not yet. You have to share. I think you have to share your.
I did.
Oh, you did. Rita, can you give her some advice?
Rita has. Oh, there it goes.
Okay.
There you go.
All right, so look at the beautiful screen that I was starting with.
Yes.
I mentioned very quickly that we're interested in growth because it's a really good measure of what kids actually learn from one year to the next, and it also allows us to figure out what contributions schools have. And so when we lose a year of testing, as we did last spring, it has a dramatic impact, not just on the snapshot for 2020, but on our ability to know in 2 separate growth periods how much kids have progressed. I talked about the big findings of our study of 20 states and all the kids in it. We projected what they would have learned had COVID not happened, and then figured out what COVID impacts were on their learning. And very consistent with the messages that you've heard from the speakers this evening, there's an inverse impact. It's negatively more negative for more disadvantaged students. The larger your learning deficits were when you came into COVID, the more difficult your learning losses are. We are going to see a much wider spread of students' knowledge and skills coming out of this, and that's going to have a profound impact on how the system is expected to respond. The current system that we have today does not fit the needs of students, and so we're going to look for a year of reality that is going to come to us next year. I don't think we're going to see a lot of spring assessments this year, so we're going to have 2 years of fuzzy, not much information about what kids know. But next year, it's all going to come pretty clear, because you might be able to get away with not testing this spring, but you will have to test in the fall. So by the end of the 2021-22 school year, we will know how bad the hit of COVID really is. Our own estimates at Credo are that this is a 6 to 10 year recovery program. We are measuring now how quickly we think students can recover, and our own estimates are really dramatic, long-term recovery programs. But it's going to take districts and states a long time to figure out how to actually meet students where they are, that individualized instruction that Professor Hanishek talked about, how we're going to deploy resources differently, whether it's the human capital solution that Professor Hanishek was discussing, whether it's giving students individual savings accounts so that they can go get tutoring, or they can go to summer school, or they can pick up extra resources along the way. We haven't figured any of that out yet. That's a conversation that has not even begun, but it is one that lies ahead. And all the things that Dr. Rogers talked about, I think, compound the crisis that's facing the students and the education system as we move forward. So that was my slide deck. And now I will stop.
Wonderful. Well, thank you, Professor Raymond, for both your wonderful presentations. Thanks. Closing out your share so that we can see everybody's face a little bit bigger. And I will open up questions to the commissioners, to either Professor Raymond or Professor Hanishek, or both. Commissioner Kalfani, did I see your hand go up?
It did go up, but she actually answered my question as she was speaking, so I'm okay now.
Wonderful. Other commissioners? Any of the staff? Commissioner Cotto? Ron, you're muted.
Thank you, Dr. Raymond and Dr. Hanishek. Dr. Hanishek, you really blew my mind out. I never had that perspective of economic loss, future economic loss due to this pandemic. Very enlightening. But my question is for Dr. Raymond. You said that you're accompanying 20 states and looking at the impact of COVID on learning. And, each of the states, they're run by different school districts, and school districts set up their own policies. Here in LA, the second largest school district in the U.S., it just basically shut down for the whole year. They didn't look for targeted or tiered for these low-income families. Just across the board, they shut down. But there's school districts throughout the country. At each phase, they were adapting. In the beginning, it was to get enough PPE, and then after that, it was contact tracing and testing, and they were adapting. They went outdoors. They did a hybrid type of learning. And so, is your data about these variances an average of those that have totally shut down, or is it more for those that are like hybrid?
So thank you for your question, Commissioner Cato. So remember that the analysis that we did looked at only what happened by the end of the last school year. And then we are basically extrapolating about what happened this year. Last spring, there weren't these multiple adaptations of hybrid learning and of outside learning and of big pivots in terms of changing the models. Districts either figured out a way to go completely remote instruction if they had digital technology and they had enough equipment in the hands of educators and students, or they shut down. And LA was one of the ones that basically could not move forward because they did not have the capacity to pivot to a digital-based learning system. This year, we see all kinds of proliferations of models. We see schools that have the students in the classroom and the teachers remote. We have schools where the teachers are in the classroom and the children are remote. We have systems where some students are remote, some students are at home, and the teacher is supposed to do both. As we move forward, we're going to be able to track which districts adopted which kinds of practices and see what happens to the impact on student learning and on student recovery. But we don't have any of that information today.
We do have a little bit of...
Thank you very much.
I'm sorry. We do have a little bit of information to suggest that people in class tend to be more advantaged, that have any in-class instruction tend to be more advantaged than those that have no in-class instruction.
Yeah, I don't know if you're aware the county of Los Angeles gave schools a chance for exemptions to do outdoor class, and most of them were private schools that applied, and some of the charters, but I don't think there are very many or any LAUSD schools. It was just all across the board. Let's shut it down. So.
Well, if I could amplify your point, sir, one of the things that we know about the Los Angeles area is that three things went up in a big way. One was private school enrollment. So all private schools just exploded with applications for kids going to private school, which is interesting because before COVID happened, private schools were in a death spiral. They were losing enrollment, they were having higher costs and having a really difficult time. And now they are the sort of darling of, we have figured this out and we have got in-class instruction and we're safe and we're distant and all the rest. The second is that there's been a huge migration into charter schools. So the charter schools in the area, along with others across the state of California, are not only reporting large gains in enrollment, but they are reporting huge multiples of their former waiting lists. So there used to be 350,000 students in California on the waiting list to try to get into charter schools. That is more than quadrupled this year. So there's a huge pent-up demand to try to get students into places that are actually operating. And the third group, for better or for worse, is that there's a huge migration into online schools. And my team has a study that we did several years ago that shows that students in online schools are not being well supported academically, that their gains are really pretty horrible, and that I have real concern about whether during this pandemic these online school providers have actually been able to amp up their game in order to be responsive to the needs of students, or whether we're just going to see more students getting the prior online learning that was being provided by these suppliers in the past. Again, we don't have any information on that yet, but we will sometime.
Okay, just one last thing, sorry. Dr. Hensher, I think your suggestion of how teaching has to be focused on individuals, I think that's critical to get this thing going. And I hope somehow your institute could be, helping the school districts look for ways to make this happen, because I think, listening to your reports, it's pretty disheartening how much these kids in the disadvantaged areas, if they're going to be depending on like mass teaching to go forward, it just doesn't seem like it's going to work. So hopefully, you'll come up with the suggestions for the school districts to be able to put that into practice. So thank you to you both for, all your time.
Thanks very much. Let me just add one little note on that. It turns out that in individualizing instruction is one of the places where technology has really had a positive impact, and that there are some nationwide school systems now, essentially school systems, that are offering more individualized instruction that takes advantage of growing technological platforms. And so here is a place where we might be able to pull out in the future if it's allowed. But there's a lot of, as you know, in LA, a lot of negotiating about what the future schools will look like and what is possible and so forth. Hopefully things like individualized instruction of that nature will be part of the package.
And hopefully that's going to reach those that are in the socioeconomically disadvantaged areas, or target them first. They're the ones that need it the most.
Thank you.
Councilor Vaughn, you have a question?
Yeah, thank you, President Mandel. As a father of two children actually in private school, and actually one having an 11th grader who actually has individualized learning of a class across the country that she takes because her school doesn't offer it, and that her school does. The one thing you had mentioned earlier is having teachers who teach online. Some are better than others. In doing so, is there a way for schools to objectively look at what teachers can teach better online, or do teach better online, if there is going to go forward some sort of a hybrid program? So coming up with sort of an objective criteria for how teachers, and that may be children's test scores or other things like that. But have you thought about maybe some objective criteria to look at what teachers teach better online, not necessarily than in class, but that children do better online with those teachers?
Sure. I should say that there's a very long research tradition of people studying schools and trying to find more objective ways of quantifying and identifying which teachers are most effective at providing instruction. And this work in the in-class version has been called value-added modeling, where there's an attempt to separate out all of the influences from the family background, from the neighborhoods, and so forth, from what the school is adding to the learning of the child. And it turns out that you can do that reasonably well with sufficient testing information and so forth. Washington, D.C. has actually used that system to reward a large number of teachers in Washington, D.C., and to actually fire teachers that were completely ineffective in teaching. You can think of doing the same thing online. In fact, it might even be easier because you can get more immediate feedback on whether kids are learning or not. And the whole secret relates in part to what Dr. Raymond was talking about the importance of looking at learning growth over time. If you look at the growth in learning over time, it takes into account a lot of the background factors and eliminates them and allows you to relate them more closely. One final note, though, there's lots of teachers who are teaching in subjects that are tested or in grades that are tested and so forth. But what we find is that it turns out that supervisors are pretty good at identifying who's really good in class instruction and who's really bad. There's a lot of confusion in the middle of the distribution, but identifying the extremes of the distribution. And for parents, I don't think that you have any doubt which of the teachers your kids have been particularly effective and which aren't. The other teachers in the school all know who the best teachers are and who the less effective teachers are. We've just never been willing to use that information or been able to. But you can do it online in the same way that you can do it in class.
Thank you.
So I have a question for both Professors Raymond and Hanishek. You can individually answer them. I think one might be more in each of your categories, but they overlap a little tiny bit. Are there any ongoing or new studies that Stanford or other groups are doing that are comparing the different school systems that we have? For example, looking at the loss or potential, hopefully when we come out of this, gains of public versus the independent schools versus the parochial schools versus the charter schools, both from an educational gain, but then also because of the economic ramifications, we know that the numbers of kids are changing where they're going. There are going to be economic ramifications as well. So if you could both address those issues.
You first, Becky.
Okay, so first off, we don't have a whole lot of performance data on parochial or private schools because they don't participate and are not required to participate in any of our student performance measurement systems or assessments. Having said that, I think that there are some other less strictly outcome data that we can see. We know that families are moving to these environments and are keeping their kids in charter schools if they're moving there, or moving into private schools and retaining their enrollment in private schools. So those are indirect measures of what they think about these schools. The bigger problem for me over the long haul is that we don't actually see what happens to these students until they're well out of the K-12 system and actually actively participating in the labor force through whatever additional training or job skills development they've had. And so we don't have the ability to move backwards into those various sectors and assign the economic impacts to them that we would like to, because we simply don't have the ability to follow kids that far into the labor force. Hanishek, what do you want to add?
Well, I would just add briefly that as a first order effect, it doesn't matter where the kids got the learning. All that matters is how much learning they got. And so to the extent that some charter schools are doing better than some traditional schools, those kids will be better off economically in the future. Similarly for private schools or parochial schools, although as Mackie said, we don't have much direct evidence there. There's a little bit of tangential evidence on parochial schools, but it's very old and not very precise.
Wonderful. Any other commissioners have a question? Seeing nothing in the chat or nothing, no hands raised. We're honored, Professors Raymond and Hanashek, that you would join us. We're humbled that individuals as yourselves, so world-renowned in your fields, would take the time to come to speak to us. One of the little tiny things, as I mentioned before, that's been a benefit of this COVID pandemic is that we've had the ability to get experts such as yourselves to come to testify and to educate us. We're totally appreciative of your time, your effort, your research, and your abilities to educate the LA City Health Commission and the people of Los Angeles. Thank you very much for participating today, and we're totally appreciative of your efforts. Thank you. Again,
could I just add something about that? The reason we do this is because we're convinced that these issues are the future of the U.S., the future of the country, the future of Los Angeles. And so we are making our attempt to influence influencers to, in fact, push forward on these matters. They're obviously highly political. Almost everything we said tonight is highly political, that you don't have to spend much time with the Los Angeles Times to understand. And so the influence that you can offer, I think, has direct implications for the future of your citizens.
Thank you. I agree 100%. I think you're totally on point. Thank you.
All right, don't be strangers. If there's anything else that we can do to help, please reach out.
Thank you. And we're going to have a very interesting additional talk. You're welcome to stay on. We recognize the fact that your professors, your researchers, that you guys have a lot on your plate. You're welcome to stay. We will not take it personally if you decide that you have other things that you need to do or you want to eat dinner. So thank you once again. We're really honored that you've come to meet with us.
Bye, guys.
All right.
Moving on to the next agenda item, we're also honored to have two leading experts from APL Health, Craig Poschhofer, and if I destroyed your name, I'm totally apologetic. Please correct me. And Terry Smith. I could guarantee you that's a much easier name to pronounce. and Craig, I apologize if I mispronounced your name. I'll tease everybody and say that English is my second language, just like Brooklyn, New York. All right, you guys are on.
All right. Well, thank you. Terry's going to share the slides here for us. Yes, he is. It's like, where'd it go? I'm sorry. All this time. Okay. And I think Erica could probably share the slides if we need her to. Yeah, for some reason it's not letting me do that.
Or if you want to try logging out, Terry, and then logging back in, since that worked originally.
Okay. And last from my close, it's Craig Poschhofer, but not the easiest.
Terry's back.
You're muted, Terry.
Craig, I seem to have lost the presentation. Wow.
Erica, do you have it that you could pop up?
Let me give it a try here.
Here we go. Do you see it?
Not yet. I think you have to share. You have to share your screen with us.
Okay. You're not seeing it because it's saying that it's sharing. Can't show your screen. Oh, I'm getting a notice saying that I can't show my screen.
Erica, can you make him a co-host or whatever the term is? Please.
I'm trying that also.
Okay.
It doesn't seem to be working. Let me see if I can pull it in.
Hey, Terry, on the far right-hand side, next to the three dots, there's a thing that says Present Now with an arrow. If you click on that, what do you get?
I get present your entire screen in a window with tab.
Right. Can you click on that? Go to your entire screen. It'll work.
Do you see it now? Yes? Oh, okay. This is really strange. I'm getting an error message saying that something's occurring with screen sharing.
Okay. Ron, are you at a computer or are you on by phone? If we send you the slide set, can you pop it on maybe?
Yes, I can give that a try.
Did you get it sent to you, or if not, I can send it to you?
I believe I have it set up. Let me give it a try now.
Okay, let's try it. Thank you.
This will really be worth the wait, folks. I know it's really, you're like, what's going on? But this is going to be... I've seen
your presentation. It's definitely worth it. And if we can't do it, definitely a millennial can get this up.
All right, does everyone see the screen in front of them?
Not yet, Lauren.
There we go.
I like a millennial, you see. That's what
Thank you, Marianne.
All right, so good. Thank you, Lauren, for saving the day. We appreciate that. So, Charlie, I think what we'll do is you just let Lauren know. She'll advance the slides as you speak. And Craig also, if you're going to jump in also, we appreciate that as well. And if you guys got the floor. There you go.
Okay. Yeah, well, thanks so much for inviting us here today to talk about another significant public health issue that has continued, of course, even during COVID-19. I'm Craig Wolf, I'm Associate Director of Government Affairs at APLA Health. Terry Smith is the Director of Sexual Health and HIV Prevention Services. So I want to kick us off just with a little bit of background about STDs, and then Terry's going to talk more about APLA Health Services and how we've adapted during COVID. So next slide. Just wanted to quickly share a little background about the organization for folks who aren't familiar. So APLA is one of the oldest and largest HIV service providers in LA County. The organization was founded in the early 80s, formerly known as AIDS Project Los Angeles, and continues to provide a number of services for people with HIV across LA County. A few years ago, the organization also became a federally qualified health center. So we now have 3 health center locations across the county in Baldwin Hills, Long Beach, and Miracle Mile. And we'll soon be expanding our services into South LA and opening another health center on the campus of Charles Drew University. And our services are open to everyone, but we really focus on providing quality care for the LGBT community and people affected by HIV. Next slide. So, of course, we're here to talk about STDs. I imagine most folks are aware that we've been invited here because the county, like the rest of California and the rest of the country, is grappling with a significant STD crisis that has likely only grown worse during the pandemic. So I just included here the most recent data that we have. We don't yet have data from 2019 and 2020, but we do have some kind of preliminary reports from the Public Health Department. I think the most important pieces to call your attention to here are just increases over the last 10 years. So from 2008 to 2017, cases of chlamydia, the rate increased 34%, gonorrhea 183%, and syphilis 189%. And one of the most startling piece here is congenital syphilis cases, when syphilis is transmitted from mother to baby, and congenital syphilis cases increased 671% from 2010 to 2018. In 2018, there were 54 congenital syphilis cases. That was the highest number ever reported. We've heard preliminarily from the Public Health Department that there's actually been over 120 cases of congenital syphilis in 2020. So looking at the increase from 2018 to 2020 is really startling, and I think just really calls attention to the crisis that we're currently facing. Next slide. And like I said, we don't yet have 2020 data, so we don't have a precise accounting of how COVID has impacted the STD epidemic. We know that folks are continuing to acquire and transmit STIs despite social distancing and stay-at-home orders, and service availability has been reduced. So some county STD clinics were closed. Some organizations had to reduce services. So even though there might be slight decreases in the number of reported cases, it's likely due to decreased access to services and not necessarily because STDs weren't being transmitted. And just a couple of points here that I think really highlight accelerated STD epidemic. So in 2020, the CDC confirmed that a new antibiotic-resistant strain of gonorrhea was spreading, and then the California Department of Public Health issued an alert late last year about the rising number of disseminated gonococcal infections. So this is kind of increased complications due to untreated gonorrhea. And then important to note here, STDs don't affect all communities equally. So there is a disproportionate impact, especially on gay and bisexual men, people of color, especially women of color, transgender individuals, and youth. And many of the same drivers of STDs are the same drivers of other health inequities, poverty, homelessness, stigma, lack of access to culturally appropriate services. And I just want to highlight this last piece here, increasing meth use. It hasn't been discussed here, certainly an important piece to focus on the dramatic increases in meth use in LA County over the last several years, and it's suspected that increased meth use and increased substance use is a significant driver of the STD epidemic as well. Next slide. So I think an important point to highlight is that we know kind of what the effective strategies are to address STDs. So improving early detection, expanding access to testing, interrupting disease transmission by treating individuals and their partners, educating the community, and then also impacting health provider behaviors so that healthcare providers are properly screening and testing their patients. The challenge is the public health infrastructure and funding is severely inadequate to address the current scope of the STD epidemic. So looking at the next slide, just a brief run-through of kind of where funding is at the federal, state, and local level. Next slide. So looking federally, there have been, federal funding for STDs has been pretty much stagnant since 2003, and the spending power has decreased significantly since that time. So after adjusting for inflation, the buying power has decreased about 40% in terms of the federal STD funding, and there was a very small increase in federal STD funding in 2019 of $3.5 million, $3.5 million nationwide, and that was the first funding increase since 2003. California has also increased funding for STDs. So in 2019, Governor Newsom and the legislature allocated an additional $7 million annually for STD prevention that was allocated to local health jurisdictions, including LA County, to address rising STD rates. Advocates have requested a much larger investment of $20 million. $7 million is certainly not enough, but certainly grateful for that investment. And then in 2018, LA County allocated $5 million in tobacco settlement funds. That was a one-time allocation, and advocates, including APLA Health and others, had requested $30 million at the time. It's my understanding the city of LA currently doesn't allocate any funding specifically for STD activities. So I just wanted to give a brief background just to highlight kind of the dire picture in terms of the STD epidemic that we're facing, and then really the lack of funding and infrastructure to address the crisis. But just want to next pass it off to Terry so he can talk about what we're doing at APLA Health with the resources that we do have available.
Thank you, Craig. Next slide. So we like to show our team. These are the people who help provide the services. And what is notable about this is that this is really a reflection of the communities that are most impacted by HIV and STDs and all of that. And so I always like to, whenever I talk about the work we do, like to show people who are doing the work. Next slide. So a lot of things that happen in response to the stay-at-home orders and all of that, it impacted the way that we do business. And basically a lot of our work went from bringing people into our facility to really doing a lot more telephone encounters and virtual programming. And so specifically as it relates to STDs, we have restricted our services only to folks who had an STD. They had to actually have symptoms, and when they came in and got treated. But of course, that was the process too, because we were so busy dealing with COVID. And so one of the ways we really wanted to kind of educate the community and get information out there was to really use our social media platforms, so Instagram and Facebook and all the things that these young people are into to get information, to really find out a way to make sure that they have information. So what's listed here are programs that are targeting for folks in the community who are most impacted. So Party-Wise, those are folks who are struggling with crystal meth. Project Impact is a program that really works with young people, young men, really helping them make better decisions and helping them understand the connection between their feelings and behavior. In terms of sexual health, stuff like PrEP, one of the things that we have seen is that during this time there's been an increase in the number of people who are accessing PEP, right? And so we're getting first-time PrEP users, which is great, but also folks who are finding themselves in need for PEP. And then other programs targeting transgender community, and then a program targeting young Latino and young Latino gay bisexual men. Next slide. And this is just like to talk about the social media and really trying to get conversations out there, encouraging people to stay abreast of information, to kind of talk about feelings and all of that. Next slide. And so one of the things that we did, because of the fact that we were not able to bring people into our site, is that we started distributing home test kits. And so we would mail home test kits to folks, and we'd also mail safer sex supplies. And we started this program in like late August, and to date I've done about 150 kits that we've mailed out to people. The positivity rate has been low, but the good thing is that people are using this as a way to learn their HIV status. We even had someone who was already HIV positive, but wasn't really sure how to get back in care, so they fell out of care, so they took a test, and then as part of that testing process with them, then we linked them back into care. And we're looking at extending this also to maybe start mailing STD kits as well. Again, giving people additional options, and now that vaccine is here and other things are happening, we still want to kind of expand and really use this at-home test kit process, because it's really been something that we've seen be fruitful. The other thing that we're going to be doing too at APLA, we're going to be opening up a Sexual Health Express clinic at our Baldwin Hills facility. This is a clinic that is going to be state-of-the-art, where if someone comes in and is just coming for a regular checkup, they could be in and out within 20 minutes. If they need treatment, it's going to take a little bit longer. But we're really trying to give people as much information as possible, do it as quickly as possible, make it as fun as possible, and really begin to just create a new environment around people accessing ST services and sexual services. Next slide. And then, Mark, is there a play button there that you can push?
I do not think so.
Okay. Well, we have this great video. It's amazing. That we use to just really promote swab and trauma-between. That's our at-home testing program. And really, again, it's just about trying to normalize the process of HIV testing, meeting people where they are, and using that as an opportunity to then link them to other prevention services, or get people to request home safer sex kits and all of that. Next slide. And a lot of this work is done online, and so we have a prevention website, the link.la, where people can get all this information I just presented to you and then some more. And then in terms of PrEP, we've also had a PrEP Express website that is really designed to help people if they have questions about PrEP. They can make an appointment to have a conversation with a navigator to get linked into our medical services and all of that. And so our response to COVID and trying to ensure that sexual health services are still available to people is really kind of utilize and maximize our social media platforms. Next slide. And then this is a screenshot of the website. Next slide. And the PrEP Express website. Next slide. And turn this back over to Corey.
Yeah, great. Thanks, Terry. So just the last thing, Bob, just wanted to highlight some of the current advocacy initiatives that we're working on. At the federal level last year, that was launched the first national STI strategic plan. So this was a significant development. The federal government has never launched this kind of strategic plan to address the STD epidemic. But there was a significant and notable shortcoming that there was no commitment of funding to implement the plan. So this remains a top priority at the federal level in terms of developing implementation strategies and allocating the resources necessary to implement that plan. At the state level, APRI works with a number of other organizations, including Essential Access Health, who I believe is represented on the call, the Los Angeles LGBT Center, and others, to advocate for additional funding and legislation to address the STD epidemic. So this year we're requesting an additional $3 million that would be added to that $7 million. So that would bring the state total to $10 million for STD prevention and control activities. We do scale back our apps just because so much attention and resources are rightly focused on addressing the pandemic that we have scaled back our apps from what they were 2 or 3 years ago. We're also working on legislation, again really being spearheaded by Essential Access Health. So this is authored by Senator Richard Pan from Sacramento and includes a number of provisions to expand access to STD testing and treatment. I'll just run through these quickly. The Family Pack program is a program that provides family planning and STD services to low-income and uninsured folks with family planning needs. This bill will expand eligibility for that program to include low-income folks who don't necessarily have family planning needs, which will include many LGBT folks. The bill would also require public and private insurers to cover home testing, and also expanding folks in community-based settings that could provide rapid STD testing. Also revising current law to increase utilization of expedited partner therapy. So this allows providers to prescribe treatments for partners of individuals for STD treatment for partners of individuals without actually seeing them. And then also updating state laws to require congenital syphilis screening during the 3rd trimester of pregnancy, because it's currently only required in the 1st trimester. So that was it for our presentation. I think that was a quick and dirty overview of what's happening with STDs in LA County and California at large, but would love to answer any questions that you all have.
Wonderful. Thank you both for your presentations. Lauren, could you get out of screen share so we can hopefully see everybody? That's perfect. Excellent. Great. So first, Terry and Craig, on behalf of the City of Los Angeles and the Commission, I want to thank you both, but also APLA for 35 years of service, superb, stellar service to the people of Los Angeles. And for your advocacy as being a role model for the whole entire country. Because what you guys have been doing for decades has actually been really picked up nationwide, and your model works well. The question I have to you several. One is, with the increased numbers of the STIs that we're seeing, and with contact tracing, have you found them linked to meetup apps or phone apps, and if so, is there a way to use those apps to somehow do further contact tracing?
Do you want to take that one, Tyler? Yes, Craig. There's a relationship between people meeting up on the hookup apps and increased STI and all of that, and I know that a number of the larger ones like Grindr and Jack and some of the other ones have partnered with community-based organizations to deliver messaging around the availability of STD testing. PrEP, they've been a really great partner getting the word out about PrEP and all of that. And so I think that there are continuing opportunities for us to use them as a partner to make sure people know where resources are in the community.
second question is kind of economic. Maybe Craig, you have a better sense of this. What's the annual budget of APLA? And since you've become a federally qualified health center system with multiple health centers, is the reimbursement that you get from billing the federal government for care enough to keep your doors open, or do you have to do a lot of fundraising or get extra grant money to support it?
Yeah, I mean, just in terms of operations, I mean, since APLA became a federally qualified health center, that has brought additional resources to the organization. I think when I started about 6 or 7 years ago, the budget was around $20 million, and it has since tripled in size over the last few years since becoming a federally qualified health center. So that has brought additional resources to the organization, but does not necessarily provide adequate funding, to provide comprehensive STD services, especially for uninsured folks or folks who can't bill insurance for whatever reason.
Wonderful. The other question is, the city and the county of Los Angeles have different roles in regards to health, as you know, and the question we've always had on the commission is that people collect data that is city-focused. So does APLA, when you're collecting your data, do you see where people live by either zip code or by community? And if so, do you have an idea of what percentage of the patients you're seeing live in LA City versus outside the city elsewhere in the county?
Well, so we do collect that information. I don't off the top of my head know what that looks like. Do you, Craig?
Yeah, we checked in with some folks at the city this morning, and they said that they don't receive city-specific STD data. So, we have county-level numbers, but there's not LA City-specific STD report.
Right. So that always amazed me, and that's a much bigger question that's above our pay grades. But what I would say is if you guys collect that data, it'd be really interesting if you could come back to us and just send it to us so we would have an idea of what percentage of the patients that you're seeing are living in LA City, and specifically in regards to STIs or STDs, which one of those, are actually city versus county. It would kind of help a tiny bit in our long-term planning and in our report that we make annually. So that would kind of help us. It amazes me that the county of Los Angeles doesn't collect that data and make it available to all of us. So we could do strategic planning, and we could do strategic planning, and the city council could do strategic planning. And we've asked them to do that, but that's something that we've not gotten a lot of response from. And then the last one on an economic basis, how much money do you get from the Department of Public Health from LA County?
Do you know off the top of your head, Taylor? I'm not sure.
I don't.
Okay, well, yeah, no problem. So same thing. If you can find that information and sure. The commissioners, I think that would help us a little tiny bit. Last year in a fiscal year, LA DPH had a budget of $980 million, to give you an idea. With the CARES Act, I don't know what's going to happen with this new bill that is being negotiated on the Hill right now. But from the CARES Act, the Department of Public Health got, in my estimate, about $250 extra million. So approximately they got $1.25 billion with a B. That's larger than some state budgets. It would be interesting to see where that money is going. You guys are doing a yeoman's job of really helping the people of the county of Los Angeles and city of Los Angeles. And you're doing it with a budget that was $20 million, is now up to $60 million. Most of it's coming from federal funding for patient services, client services. So you're not getting a lot of the grant money that's really coming in, though you probably have some grants and fundraising activities that you do as well. But it's really interesting to see the county with the amount of money that they have, that institutions and organizations like yours should be getting more funds, in my opinion. But having said that, I'll open up to the other commissioners. Commissioner Kalpana, I see that you have your hand up.
Thank you. I want to first just say thank you to both Craig and Terry presenting. I have a personal interest. We've been having lots of conversations as it relates to COVID, and I think with so much attention to COVID and just really the shift in how we deliver care, I still just know what's happening in LA County with rates hasn't disappeared with COVID, and needing to be creative with how we respond and continue to respond to treatment and testing. And this is something that Chair Mondale mentioned, a question around data and by cities. I don't know the city breakdown, but I know there's a lot of information that's broken down by districts. So looking at the districts across the county, District 2 has the highest rate as it relates to STDs. And I'm not, when I think about District 2, I can't think about what cities all fall into that, but that is a district with one of the highest levels disparities of rates. So I just wanted to add that tidbit in terms of looking at data. But I'm just curious, with COVID and having to transform how you deliver care. I know you've transitioned to doing things virtually. But I'm also curious to hear more about how creative you've been able to be, right? So with social distancing, folks still being fearful and going into clinics. So you've had kind of this wave of a period of time of whether it is care done via telehealth by telephone or video or curbside or these drive-through visits. And I'm just curious to hear how successful were those? Did those things increase folks being seen? And I know it just all varies, but just curious to hear more about, in any of those things beyond just kind of the website or social media pieces, were you able to get folks in for testing or screening through other means during this time?
Most definitely. I think when we look at, in particular the QHC side of the house, primary care, behavioral health, dental. So dental, we took a big hit. It was just hard to do dental services during this time. And so our mental health side, our behavioral health side, we thought we were doing telehealth with behavioral health. And that seemed to work really, really well for the community. People really respond to that. And their numbers actually increased during this time, which is not surprising because of the times we're in, but the fact that people were able to utilize that and benefit from it was great. On the medical side, we did take a hit for a while because we was trying to figure out how to navigate that between, we talk about telehealth and all of that, but some people don't have access to a phone and don't feel comfortable and want to come into a space and all that. And so trying to get that balance of making that happen. But right now we have a very good balance, so we are trying to do more telehealth because we think that really works well for some people, but there are people who need to come in and see their doctor. Right. And so then how do we do that in a way that's socially distancing and all that stuff that you're supposed to do? And so we have navigated this last year very well.
And then my second question has to do with, I know you talked about at-home kits. Talking seems like more as it relates to HIV, but I'm just curious about other at-home kits for other STDs. And has there been a pickup, or how responsive have folks been for that?
So the home testing for HIV, the at-home HIV test kits was a pilot that we went to see how responsive people would be to it. And the response has been, as I mentioned, very well received in the community. We might want to expand that to do at-home test kits for chlamydia, gonorrhea, those two in particular. The one for syphilis, there's some challenges with it, but we always need to expand that, again, to just provide an additional avenue for people who don't want to come into a clinic and might feel more comfortable ordering a test kit at 1 o'clock in the morning, that we send to them that they need our support, they can do it, get the results and all the other stuff. So we will be expanding that. I would say probably in the next couple of months to include the STD portion of it as well.
And last question, as it relates to young folks, in we did a survey, we saying Essential Access did a survey, and you had young folks that were feeling more comfortable with telehealth or just for confidentiality issues, but then also realizing for some, you still have the issues in wanting to be seen in clinic. But at-home kits did come up for youth. Are there challenges with, or what are challenges as it relates to either billing or other things for youth? Although it is a confidential, sensitive service, what are some of the barriers or challenges with at-home kits for young folks?
I think that it's one, making a phone call, making a connection with the staff to actually get the kit, and then once they get the kit, taking a test, and then the other part is taking the test and then reporting the results back to us, because then we have to report that to our funder. And so those have been some barriers for us, and one of the ways that we have kind of addressed some of those is that we have a person who runs that program who's a very big personality and just makes people feel really comfortable and welcomed and all of that, and will call somebody and say, hey, you know what, I sent you that kit, haven't heard back from you, and that kind of thing. We also incentivize people telling us their test results, so that seems to help too. I think we do like a $10 gift card, which just to encourage people to give us that information so that we can report the test kit. We pay for our test kits through funding from the CDC because we have a testing program through the CDC. So the whole billing piece isn't an issue for us with young people. So that really helps.
Okay. Thank you. I won't take up too much time, but again, thank you for the presentation. I was excited to hear it. So just thanks again.
Any other commissioners want to raise your hand or chat me and have a question? Seeing that, gentlemen, your presentations were excellent. Once again, thank you so very much for coming tonight. And more importantly, thank you for doing the great work that you do in our community, making our community better. And let your board know that the LA City Health Commission really truly appreciates the great work that APLA has done for 35 years or so. We're honored that you come tonight. We truly appreciate it. And then if you can get us that other information and send it back to us, we appreciate that as well.
Well, thank you. We'll pass it out. Appreciate it.
Thanks. Thank you, Lauren, for saving the day on that presentation.
Thank you, Lauren.
And Sarah and Marvin for coordinating. For the public and for the commissioners, please know that from month to month, our 3 research associate interns are volunteers who do great work for us and help us bring these excellent speakers to help us so that we can do the work that we do. They do so much more that you guys don't even know, and I personally am appreciative, and I think that you all should be as well. Going on to agenda item number 4, any new business, that new ideas people want to address for conversation? And I would say also that, again, you can always contact the research associates and let them know. They'll track down, they'll get information for you, and they'll assist you in getting the information that you need.
Sorry, Chairman. I think one item that I have already submitted to the interns, and I thank them for their help as well, is the impacts of telehealth during the COVID-19 pandemic. And also another thing, I think that I was reading about the fight is in us, or on us, the fight is on us, a campaign to get folks to donate plasma after they've tested positive for COVID-19. I think it would be interesting to hear from one of the representatives about the type of outreach they're doing to get folks to donate plasma after they've tested for who's positive for COVID-19 and the impacts for recovery, that it would have. So.
Right. So in regards to the second topic, the first topic I know they're working on. So we have that for the next agenda, I believe. In regards to antibodies or plasma, the federal government has kind of backed off on that a little tiny bit. And the reason for that is that there's been some monoclonal antibodies that are being manufactured in regards to 3 FDA trials that have gotten some excellent results, which has less risk than the pooled specimens. It is true for patients who are extremely sick in critical condition that the plasma has been shown to be beneficial, but monoclonal antibodies probably have less risk. So I think there are some federal studies that are going on comparing in a blinded fashion that question. I'm not opposed, and I don't think any of the other commissioners would be opposed to learning more about it. But maybe if we're going to do that, we should, maybe get some people to talk about the monoclonal antibodies as well, and do it together, so we can actually learn more about it. I think it's a good idea that we can research for you. I think that's a good idea.
Excellent. Thank you.
Any other commissioners have an idea? Something you want? If not, we're all open. You can email us. It's only better to go through either Erica or through the interns. Because of Brown Act, we can't have email exchanges that have more than the majority of the commissioners, so we have to be very cautious. You're always welcome to email a couple or several commissioners if you want to get some input or discuss things, but less than 50%, please. And so it's always better to go through the interns or through Erica in the city clerk's office, who then can get input from all the other commissioners. We're always open for new ideas. Seeing no other ideas, can I have a motion for adjournment? Commissioner Cotto, can I have a second?
I'll second that.
Second before 2 other people. So he'll be the second. Seeing no opposition, we're adjourned. Thank you, Erica. Thank you, Barack, for your wise counsel. And thank you for the tech support of the individuals in the city who are recording this and trying to make it work. I think we have to look into the problem that was brought up by the first speaker in the public in regards to the technology about why they can't hear the commission meetings and or what's going on with that. The other thing is we previously talked about, for public comment, 2 minutes plus 2 minutes plus 1 minute, a total of 5 for any speaker when we're in public. And then in some regards, we do the same thing here, theoretically. And so if people are on topic and are addressing the issues, they should have a little bit more than 2 minutes to speak. On the other hand, if people are not on any issue or just doing public comment, they get 2 minutes. So to make that clear, if there are other commissioners that have ideas on that, please let me know. Anyway, be well, take care, and be safe. Socially distance, wear a mask in public, especially indoors, and get vaccinated as soon as you're legally able to. And if you have weird symptoms, see a doctor. Don't be afraid to see a doctor. There you go. All right, be well. We're adjourned.
Thank you.
Thank you, Erica. Truly appreciate
Thank you.
inaugural running of the show.
Definitely need to learn some more tech skills. Thank you.
Yes, you guys are way ahead of me, but I knew that if I went to Lauren, Sarah, or Marvin, that one of you guys would be able to do it. I saw that Sarah was in City Hall, so I didn't think she had the same capability from a computer point of view, and I figured that you or Marvin would have the ability, and I couldn't see Marvin on there. I knew he was there someplace, but so that's why I went to you, Lauren. I'm glad you saved the day. Thank you.
Yes, thank you. Echo.
Thank you.
Thank you.
Take care.